Joking a sec. First of all, I'd like to say a very warm thank you for the organizing committee letting me invite here. And I'd like to say a very warm welcome to the chairman and chair lady. And a special thank for the audience for the postprandial attendance of this course. So, if you look through the literature till this time, you will find plenty of publications that report that the everyday practice in the one-day surgery and the extended day surgery is very safe. There's zero readmission, there is no complication, there is nothing happened in the pre or post or even a perioperative care with the patient at all. And if I reach and if I read such a publication, I always think on the 10th law of the House of God. Maybe you know, it's a popular work from Samuel Sim. And the 10th law is that if you don't take a temperature, you can't find a fever. And one of the very first publications that took the temperature comes from John Jackson. But before of his publication, there is an inter-hospital publication where the patients could be followed more properly than in the day-case surgery. And in the inter-hospital setting, a immediate postoperative event frequency was reported from 2.6 up to 20%, is somewhere here, yeah? So there is a high incidence of postoperative accidents, postoperative complication, but if you don't measure that, you don't find it. And John Jackson was one of the first who really take care about the postoperative complications in England. And he published this survey, which was performed somewhere in the early 19th. And the publication date is in 1997. And he took a telephone survey with 1,709 patients was followed, and 1,320 of them contacted on the second postoperative day, and they found out that there is a huge amount of complications. So if you see only the nausea incidence, the cumulative nausea incidence is 6.7%, the vomiting incidence 4.2%, the muscular pains 11.6, etc., etc. The overall cumulative incidence is 58.1. Of course, it doesn't mean that 58.1 of the patient has complications, because one patient could have more than one complication and more one side effects at one time. But it outlines that there is a really huge risk of postoperative discomfort, postoperative complications. And it doesn't work? Okay. Based on this study, we decided to make an our survey, because from 1990s, a lot of changed in the anesthesia till 2010, 2011. And we performed the telephone survey as well, including 832 patients. And from these 832 patients, 519 were contacted, and 3 of them refused the participation of this survey. So 516 patients were evaluated. All of them was included in a one-day or extended day surgery for herniated nucleus pulposus operation. And we performed a pre-designed unified questionnaire through the telephone interview between the 1st of October 2005 till 1st of August 2012. Okay. All patients were, as you've seen, neurosurgical patient, and neurosurgical patient is specially known to at least operated for herniated nucleus pulposus, especially known for low incidence of postoperative mortality and morbidity. So these data should be taken with care, because this is not represent the general patient population. It represents a very narrow and spatial patient population. But despite of it, what we found, it's very similar to that found by Jen Jackson that, for example, the sore throat, which we think it's a small side effect of the patient, it's very common. It occurs up to 10% of the patient, and I'm sorry, it's a little bit shifted above, but the very severe to miserable occurrence of this side effect is quite huge, almost 1/3 of the overall incidence. And the muscle pain incidence is quite frequent as well. Drowsiness, fatigue, headache, dizziness occurs with a large frequency within the first 48 hours. And some of them, especially the muscle pain, fatigue, and sore throat, and even the headache, could persist for longer time in the postoperative area and could serve as a very, very unpleasant sensation of the patient. I'm sorry that it shifts a little bit above. The sore throat, I signed it with red because normally we don't attribute a high importance of it. But if you look this data, 15 patients from the overall 76 patients, 56 patients reported it is almost miserable. If we ask the patient what was the most unpleasant sensation after the operation, the majority of the patient was mentioned the sore throat. Due to this questionnaire, we tried to do every effort now to limit this postoperative complication. You might wonder why the postoperative nausea and vomiting not mentioned in this table before. The reason is very simple, because no patient with postoperative nausea and vomiting has been discharged at home, and this is why there was no complication at home in that manner. But if you see, there is a huge incidence of postoperative nausea and vomiting within the first 24 hours. But after introducing a new technique, we could reduce it up to 0% till this time. It's a very few patients, so it should handle with care. We ensure a normal capney during the operation. We give 20 milligram metoclopramide, and we use fentanyl with a high restrictive manner. The next question is a muscle relaxant. So if we don't attribute a large importance of it, we can say, okay, that's a side effect of muscle relaxant, and forget it. But there is a very interesting data that after cessating, or first reducing and cessating the use of suxametonium, the muscle pain is increased. We don't know the reason yet why, but we are on it. And it was very important to take the data and to notice it. Regarding the pain, regarding the postoperative pain, 61% of the patients consider that adequate pain medication is one of the most important things after discharge. Almost 2/3 of the patients consider that pain control at home is very important. But despite of this fact, only 1/4 of the patient consider the pain, quarter of the patient consider the pain to be natural consequence of the surgery, and this is how they don't tend to lend it at all. And 2/3 of the patient used analgesics only when the pain was unbearable, and 1/4 of the patient reported that they don't have pain at all after the operation. That is really questionable data, because they should have pain, but a question arises if the pain definition and if the teaching of the patient were adequate in this case. Other postoperative complications which lead to readmission, hospital readmissions, are quite rare. In the literature, the reported readmission rate is 1 to 3%, mainly attributed to bleeding, infection, urinary retention, or pulmonary embolism. In all patient gut, we have similar, more or less similar data. We have one wound dehiscence within 1 week, which has to be readmitted. Two occasions with surgical site infection occurred, grade 1, both of them. One needed a surgical reopening, and one needed one healed with conservative treatment. And one patient suffered immediately after the operation with pneumonia. one with hypoglycemia and one with hyperglycemia that should be hospitalized. So the overall hospitalization rate is around 1%. But it's very important to note that out of wound dehiscence and surgical site infection, none of the patient was reported to the one-day surgery unit. So they were lost somewhere. So shall we take a temperature? At the original publication of Ian Jackson wrote that only 0.8% of the responding patients contacted their general practitioner in the first 24 hours. And they are rather waited for the follow-up telephone. And even in our cases, only 3.4% of the patients reported the complications without any attempt doing active surveillance. And the overall complication rate was 57%. So less than 1/10 of the complication could be discovered if we rely on the patient and we don't take active measure to get the complications. I think it's a very, very important message for us. And it's very important, it's a Hungarian situation, that none of the postoperative issues were reported by the general practitioners. So we cannot rely our system now on the general practitioners. All the postoperative complications were reported by the patients itself or not reported at all. And we have one more issue in the postoperative period, that there are some comorbidities that should be checked and should be closer controlled after the operation, after the day case surgery, especially hypertonia, which could be elevated after the operation because of the pain. Arrhythmia could occur after the increased sympathetic tone, and of course the diabetes could be disbalanced. If you see 40% of the patients suffer under hypertonia, and only 4% of the patient was controlled after the surgical procedure by general practitioner. The same is the case for arrhythmia, where 11% of the patients suffered from arrhythmia, and only 1%, less than 1% of the patients were controlled by general practitioner, and none of the patients with diabetes has been controlled by general practitioner. This is why these two emergencies occurred with these diabetic patients. So after all, we can conclude that the postoperative complications are usually minor, but far more frequent than they are considered to be. And it's a very important finding that passive observation is not suitable at all, especially not in Hungary. I'm really very surprising that you have a 75 or 76 return rate of your survey on post. We have this return rate of the telephone interview now, not with a posted questionnaires. So I think we have to do a lot in patient teaching and patient education. And active surveillance is needed to increase the patient health, the patient comfort, the patient confidence to the one-day surgery, because if they experience pain, then the patient couldn't cope with us well. And of course, it's a very, very important quality tool, because according to this data, we can improve our daily practice further and further. And postoperative treatment must be individually organized and followed, at least in Hungary, because the lack of the assistance of general practitioners. I'd like to say a special thanks for Dr. László Lázár, who permitted me to take this survey on his patient gut, and we will work together for further better results in this patient group. Thank you very much for your attention.